Welcome back, everyone. All right, to continue on the cardiology series and ECG series, we're finally at the point we can start putting some of this information into practice. Up until this point, we've used the anatomy of the heart, the electrophysiology functions, and how the ECG monitor measures and displays waveforms, and how those waveforms correspond to various electrical actions within the heart itself. So now we're going to look at actually putting this information into practice and how we use it to interpret ECGs. First of all, let's get a couple of terms together and let's revisit some of the fundamentals that we discussed earlier. The electrical foci is the origin of the electrical activity. For the SA node, your primary pacemaker has an intrinsic firing rate of 60 to 100 beats per minute. Your AV junction or AV bundle has an intrinsic firing rate of 40 to 60 beats per minute. And your ventricles or the Purkinje fibers have an intrinsic firing rate of around 20 to 40 beats per minute. Any Brady dysrhythmia is a rate slower than the intrinsic firing rate of the foci. Tachydysrhythmias are a rate faster than the intrinsic firing rate. 50 beats per minute is normal for the AV junction, but would be considered bradycardic if the rhythm was sinus in nature or originating from the SA node. The process we're going to use is a stepwise algorithmic type process for interpretation, especially as you're learning in the beginning. If you will move in this process and follow these steps, it will help you interpret the rhythms systematically and avoid the memorization trap of just saying, this looks like a sinus rhythm. This process has 5 steps. First, we're going to look at the regularity of the rhythm, the rate of the rhythm. Then we're going to look at the waves for the rhythm, the PR interval, and the QRS duration. A couple of notes about terminology. In clinical biology, the prefix A means without. And so when we describe rhythms that are not normal, we use the prefix dys. We describe these when they deviate from normal as dysrhythmias, an abnormal rhythm, not arrhythmia. There is only one arrhythmia, and that is a systole. Be systematic as we go through each of these, and then we're going to look at them in practice. First of all, let's talk about regularity. For regularity, we can look at the R to R interval. We can find the peak of each R wave on the strip and measure each R to R interval to see if it's relatively consistent. Remembering that the human body doesn't understand biology or abide by all of the rules of biology, you may have some subtle variations in your R to R interval. But when it's largely consistent, each R wave to the next measures roughly the same, we're going to call this largely regular. You may also have a case where something is regularly irregular. And this is a variable R to R interval, as seen in the middle ECG strip on the screen, but it's patterned. You can see here that each 2 QRS complexes have patterned irregularity. This is regularly irregular. The alternative, or the third choice for your regularity, is irregularly irregular. And this is a highly variable R to R interval seen oftentimes in rhythms such as atrial fibrillation. In fact, will be one of the hallmarks when we talk about atrial fibrillation. So there are only 3 components, 3 choices for your regularity. It's either regular, regularly irregular, or it's irregularly irregular. Next, we're going to look at the rate calculation. For this, it's important to note that a standard ECG strip printout will be a period of 6 seconds. Some ECG strips may print longer, some may print less, and in your 12 lead, you'll actually have chunks of 3-second strips. But it's important to note that for standard ECG interpretation, we're going to look at a 6-second strip. This can be confirmed by counting the number of large boxes in the strip and either making a line or folding your ECG printout so you're only seeing a 6-second marker. The fastest way to calculate the rate is the 6-second strip method, where you just count the QRS complexes in a 6-second strip and multiply by 10. For sinus rhythms, this is going to get you a highly variable and fairly inaccurate calculation of what your underlying rate is. However, it can be helpful to use this method when you have highly irregular rhythms to get an overall or average rate. For this one that you see on the top left of your screen, using the 6-second strip, you can see that there are 8 QRS complexes, which give you a rate of approximately 80. The next most accurate method, or the middle ground method, is what's known as the big box method for rate calculation. This is a mix of speed and accuracy. And for this method, you're going to find 2 R waves that are side by side. You would want to start with an R wave that ends on a big box line. So if we look at the 4th or 5th complex in that strip, it's fairly close to ending on a large box. And we're going to count the number of large boxes in between the complexes, and that will give us a rough rate calculation based on the following correlation. If there is 1 large box between the R waves, it would be 300. 2 would be 150. 3 R waves would be 100. 3 big boxes would be 100. 4 would be 75. 5 would be 60. And 6 would yield a rate of 50. For this one, we can see that we have 1, 2, 3, roughly 4 large boxes between our R waves, giving us a rough estimation of rate of about 75. As we look at some ECG strips in the future, we're going to count these methods out, and we'll take a closer look at the calculations for each of these. Your small box method is by far your most accurate. Likewise, you're going to find 2 R waves, that with one of the R waves being close to a large box, and then you are going to count the number of small boxes between the R waves. That number will be divided into 1500 and help you get an accurate reading. This does not work well for highly irregular rhythms, neither does the big box method, as both of those methods rely on a consistent R to R interval. Let's look at each of these a little more closely. Your 6-second strip method. So as you can see on the screen, we've placed yellow arrows marking each QRS complex, and with it being a 6-second strip, we'll take the total number and multiply by 10, giving us our rate of approximately 80 beats per minute. The big box method. Here, we're going to identify an R wave that ends on a large box. We've zoomed into the screen here so you can see on this bottom, and we're going to count the number of large boxes in between the next R wave. 300, 150, 100, 75 would be if it had 4 full large boxes in between. Since it's just to the left of that next large box line, we can say that the rate is roughly 80 beats per minute. Feel free to screenshot or take a picture or make notes of the box count correlation on the screen if you'd like. Next is the small box method. We're going to take those same rhythm and we're going to zoom in for you, and then we're going to look at the number of small boxes that exist between the 2 R waves. For this one, we have 19 small boxes between the R waves. And to find our rate, we're going to take 1500, divide that by the 19 small boxes, which gives us a heart rate of 79 beats per minute. The next step is to look at the waves. We're going to look at our ECG strip, and we're going to identify each of the wave complexes, and we're going to make sure that there's a P wave for every QRS and a QRS for every P. Then we will evaluate the PR interval, and we will evaluate the QRS duration. The best way to show you this is to actually put it into practice by looking at some waves. So let's look at our first rhythm, the normal sinus rhythm. Starting at the top with our process, we're going to look at regularity. Is the R to R interval overly regular? Yes, the regularity is regular. The next, we're going to look for the rate. Using the 6-second method, we're about 80 beats a minute. That's confirmed by both the big box and the small box method, which puts us well within the intrinsic firing rate of the SA node. Note that the name of the rhythm, normal sinus rhythm, Sinus means it should originate from the SA node. And to confirm this, we need to look more closely at the waves. In a normal sinus rhythm, we should have P waves that are present, upright, and rounded. We can see that there's a positive deflection ahead of every QRS, and we've noted this on the screen with the P, noting the P wave. In a normal sinus rhythm, there should be a P wave for every QRS interval, or the P to QRS ratio should be 1:1. We've also labeled the QRS complexes on the screen in green letters, so you can see that we have a P wave, then a QRS complex. The next P wave has an associated QRS complex, and so on through the rest of this rhythm strip. The PR interval should be between 0.12 and 0.2 seconds. This is the period between the start of the P wave and the start of the QRS complex. And we can see that we're roughly 4 small boxes here. And the last thing that we're going to check is our QRS duration. For a normal sinus rhythm, our QRS duration should be less than 3 small boxes. We can see here that our QRS duration is exactly less than 0.12 seconds or 3 small boxes. This is the normal sinus rhythm. Within 60 to 100 beats per minute, the normal intrinsic firing rate for the SA node, a regular rhythm, a P for every QRS and a QRS for every P. The P waves are upright and rounded. The PR interval is between 0.12 and 0.2 seconds, and the QRS duration is less than 3 small boxes. Now let's look at some abnormalities. We've established what normal is. Normal sinus rhythm is our baseline. The 2 rate abnormalities for a normal sinus rhythm are a fast rate and a slow rate. Sinus bradycardia is an otherwise normal sinus rhythm with a rate less than its intrinsic firing rate, less than 60 beats per minute. Sinus tachycardia is an otherwise normal sinus rate rhythm with a rate greater than the intrinsic firing rate or greater than 100. For the waves, we still should have a P wave that's present and upright. We should still have a 1:1 ratio of P to QRS complexes. Our PR interval should still be between 0.12 and 0.2 seconds, and our QRS duration should still be less than 3 small boxes or 0.12 seconds. Let's take a look at sinus tachycardia. Going to follow the same process as we did before, starting with regularity. Our regularity is regular. The QRS interval is consistent, the R to R interval is consistent. Next, we're going to look at rate. When we calculate rate with the 6-second method, we're approximately 120 beats per minute. The big box method confirms that we're between 100 and 150, and the small box method shows we're clearly above 100 beats per minute at 116 beats per minute. Let's stick a flag in that and look at the rest of our components. For our waves, are there P waves? Are they upright and rounded? Yes. Is there a QRS complex for every P wave? Indeed, there is. Is our PR interval between 0.12 and 0.2 seconds? It is. And is our QRS narrow? Yes. This is an otherwise normal sinus rhythm with a change in the rate. The rate is greater than the intrinsic firing rate at 116 beats per minute. So this would be sinus tachycardia. Let's look at the other rate deviation. Sinus bradycardia. Again, the same process we used from before. Is our rate and rhythm regular? Yes, the R to R interval is consistent across the rhythm strip. What is our rate? If we look at the 6-second method, our rate is approximately 50 beats per minute. The big box method is about 50 beats per minute. And the small box method, we confirm that our rate is about 47 beats per minute. We'll flag that portion of it and move on to the rest as we note that it's below the intrinsic firing rate. Are there P waves present, upright, and rounded? Indeed. The P to QRS ratio is still 1:1. Our PR interval is still less than 0.2 seconds. And our QRS duration is still less than 0.12 seconds. Excuse me, the PR interval is between 0.12 and 0.20. Our QRS duration is less than 0.12 seconds. This is an otherwise normal sinus rhythm with a rate less than the intrinsic firing rate. That is sinus bradycardia. Okay, on to some more complicated sinus type rhythms. The first one we're going to look at is sinus arrest. This is an otherwise normal sinus rhythm with a short period of electrical silence, and this represents a skipped firing or a skipped beat of the SA node. The other alternative we're going to look at is a highly erratic rate change for the SA node known as sick sinus syndrome. This is also called Brady-Tachy syndrome, and the rate will be highly variable and the regularity will be highly variable, even within given short strips of information. Let's look at each of these closely. The sinus arrest. For the sinus arrest, we're going to use the same process as we did for the other sinus rhythms. Let's first look at our regularity. When marching out our R to R intervals, we note that the regularity is regular until we reach a point where everything seems to just stop, a period of electrical silence. And then we pick right back up again with the regular R to R interval. That period of electrical silence is what hallmarks sinus arrest. But let's move through the rest of our interpretation. We'll flag that area for the moment. Let's look at our rate. Our 6-second method shows a rate of approximately 90 beats a minute. Note this is an irregular rhythm. Our big box method shows a rate of 120 beats per minute, and our small box shows a rate of 125 beats per minute. As we noted earlier, the big box and the small box method do not work well for irregular rhythms because they don't account for these periods of irregularity. Let's look at our P waves. Our P waves are present, they're upright, and they're rounded. Our QRS waves are present, and the P to QRS ratio remains 1:1. There is no P wave in the period of electrical silence. It is truly a period of electrical silence. If we were to have P waves or other waveforms during that period of silence, that would not be a sinus arrest. It would be a different rhythm. Our PR interval is between 0.12 and 0.2 seconds, and our QRS duration is less than 3 small boxes. This is the hallmark of a sinus arrest rhythm, an otherwise normal sinus rhythm with a period of electrical silence. Let's look at sick sinus syndrome. Using our same process that's already established, let's start with regularity. We note that when we march out our R to R intervals, that we have high variability within the rhythm, and there's really no consistency to the regular pattern of the R to R appearance. Our rate also is highly variable. It's very difficult to identify an individual rate other than through looking at the 6-second method, which gives us approximately 90 beats per minute. Let's move to our waves. Are there P waves present, upright, and rounded? We have 4 P waves marked on the screen here. While your QRS complex is on the left, the T wave is likely overriding your P wave, and you're not able to see them. So while we can't definitively say yes for the complexes that we can see, we have a 1:1 ratio of P to QRS. Our PR interval for those complexes are less than between 0.12 and 0.20, and our QRS duration is less than 3 small boxes. This is the sick sinus syndrome rhythm. Highly irregular, rotating between bradycardia, tachycardia, with periods possibly of sinus arrest, and a highly variable rate. Okay, there are also some physiologic variants when we talk about sinus rhythms. Remember that sinus is referring to a rhythm that originates in the SA node. That is the electrical foci. We've talked about sinus arrest, but there is also something known as sinus dysrhythmia. And sinus dysrhythmia is a variation in the R to R interval that's commonly found in young adult, particularly males, but also females, where the R to R interval can vary slightly based on the intrathoracic pressure. The R to R interval will change in coordination with inspiration and exhalation. And during phases of inspiration, the R to R interval may increase slightly, or you'll notice a slight decrease in the rate. This is normal physiologic variant. We would call this an otherwise normal sinus rhythm, but we can document this as sinus dysrhythmia as opposed to normal sinus because there is some variability in that R to R interval. Okay, let's discuss some other rhythms that exist above the junction but occur when the SA node begins to fail. As we talked about in the anatomy and physiology sections and the preparatory sections of cardiology, the normal firing node, the normal foci, is the SA node. But as that electrical system starts to fail, the pacemaker will degrade its way down the heart. Prior to arriving at junctional rhythms or the AV junction for an electrical foci, you may have electrical foci existing in other parts of the atria. And this can create some rhythms that still look somewhat sinus in nature, but there's variance amongst the P waves particularly. The four rhythms we're going to talk about are wandering atrial pacemaker, multifocal atrial tach, atrial flutter, and atrial fibrillation. We have one other rhythm to discuss that we'll add to this section at the end. First of all, let's look at wandering atrial pacemaker. For this rhythm, we're going to use our same process that we've established. We're going to start with regularity. Note the R to R interval is regular between each complex, noting a regular rhythm. Next, we're going to look at the rate. The rate for this is within the normal intrinsic firing rate of the SA node, but may vary slightly. We can see here with our 6-second method, our big box method, and our small box method, we find an overall rate of around 80 beats per minute. We do have P waves, but note the shape of the P wave varies slightly from rhythm to rhythm, or from complex to complex. P wave 1 is upright and rounded. P wave 2 almost seems to be inverted or non-existent. P wave number 3 has a notching to it, as does P wave 4, but it's a different shape. And then we restore back to some other normal, more normal looking P waves as we proceed to the end of the strip. They do exist though. Our P to QRS ratio is still 1:1. For every quote P wave that we have, we do still have a corresponding QRS complex. And despite the malformation of the P wave shape, our PR interval is still between 0.12 and 0.2 seconds. Our QRS duration is less than 0.12 seconds as well. Now, noting the shape of the P wave, if a normal sinus rhythm has an upright and rounded P wave, this would not qualify. This is a rhythm that originates above the junction in the atria and is known as the wandering atrial pacemaker. This is because you're getting electrical foci that are a single point within the atria, but they're not at the SA node specifically. So the route that the electricity travels around the atria creates a different tracing, and each time there's a different electrical foci, the tracing is different on the ECG machine. When we have a wandering atrial pacemaker that has an accelerated rhythm or accelerated rate, we call that multifocal atrial tachycardia, or MAT. If we note here, we still see a regular rhythm. Our rate exceeds 100 beats per minute. Our P waves are present, but again, they vary in shape and size. The P to QRS ratio is still 1:1. Our PR interval is still between 0.12 and 0.2 seconds, and our QRS duration is still less than 3 small boxes, or 0.12 seconds. Wandering atrial pacemaker at a rate greater than 100 is multifocal atrial tachycardia. The next we're going to look at is atrial flutter. Starting with our same process, our regularity, our R to R intervals are largely regular. Our rate is still between 60 and 100 beats per minute within the normal intrinsic firing rate. Our waves. Note that we don't have P waves here. We have a sawtooth baseline. These are known as F waves or flutter waves, and they can occur in fixed ratios of 1:1, 2:1 for the QRS, 3:1, 4:1, and so on. Looking at the F to QRS ratio, it is still fixed, but in this rhythm it can vary, as mentioned earlier. If we look at the immediately corresponding QRS complex to the F wave, we can still get an estimation of the PR interval of 0.12 to 0.2 seconds, although it's really indeterminate on these types of rhythms. But importantly, our QRS duration is still less than 0.12 seconds overall. This is known as atrial flutter, and the P waves in this rhythm are replaced with F waves or flutter waves. Okay, the other accelerated atrial rhythms that we'll talk about are supraventricular tachycardia and rapid atrial fibrillation. Atrial fibrillation is the only truly irregularly irregular rhythm, and atrial fibrillation doesn't have access to a P wave at all. In fact, the baseline appears highly chaotic, almost like there's vibration in the isoelectric line altogether. That's hallmark of atrial fib. Accelerated version of that would be the rapid atrial fibrillation, where it's an irregularly irregular, narrow complex tachycardia. The other version of that is what we would call supraventricular tachycardia, which is a rate high enough that you can no longer discern whether or not there are P waves present. And the reason we don't use the term sinus tach for this is that we cannot determine if the rhythm originates from the SA node or other areas above the junction. The most commonly used rate is around 150 to 155 beats per minute. We'll call SVT. But as far as the textbook definition goes, we cannot discern a rate. We cannot discern the P wave to determine if the rate is sinus in nature or junctional nature. We can only say that it's above the ventricles because the QRS complex is narrow and the rhythm is regular overall. SVT, regular accelerated rhythm with an unidentifiable P wave. Rapid atrial fibrillation is a highly irregular accelerated rate with no discernible P waves and a chaotic baseline. Key takeaways: atrial rhythms are driven by the shape of the P wave. The sinus rhythm is your base. All dysrhythmias are deviations of that normal. Practice, let the math be your friend, and remember that interpretation is as much art as it is science.